Well, hello, everyone. Again, thank you for joining us today. And as Rachel said, I am Harriet, the nurse practitioner. And probably for some of you, this is some repeated information regarding our wonderful program. We are Healthy Start, a community-based program serving the underserved, and we consider ourselves a voice for the community. And I didn't know Rachel was going to already provide some insight into Juneteenth 2024, what's happening today. And I thought it was fitting because our goal, we work to reduce infant and maternal mortality and other health disparities with Healthy Start. And we know Juneteenth is to commemorate the end of slavery in the United States. We are a part of Prisma Health Accountable Communities, as well as the National Healthy Start. You see there on my left is our Director, Kim Alston, and our VP, Ms. Angela Jenkins. Here's a great picture of our September event where we had most of our entire team, except for the Upstate Healthy Start, who joined us in September, but that's our great team there. We are, like I said, a part of the National Healthy Start. There are 115 Healthy Start projects. There are 3 Healthy Start programs in South Carolina. In the Midlands and Upstate, that's where we are here in Midlands, and we have an Upstate grant that we inquired in September of 2023 that we are working to get established. We have hired a few folks, and we're working on getting more noticeable attention there in the Upstate. We also have a Healthy Start in the Low Country and the PD area. So there are 3 Healthy Start sites here in South Carolina. And as I said before, we're part of the National Healthy Start program, which is a federally funded initiative sponsored by the Health Resources and Service Administration that was birthed in 1989 by George H.W. Bush. We are a community-driven program, and we dedicated to reduce disparities in maternal and infant child health and been around since 1991. We focus on improving birth outcomes and family well-being by supporting lives of families. That includes our mothers, our dads, our babies. We work to eradicate racial and ethnic health disparities, as well as mentioned before, recognizing the importance of fathers in healthy birth outcomes. So Healthy Start, as I said, we're in the Midlands and now Upstate. Midlands Healthy Start has been around since 1997, and the Upstate Healthy Start started September 2023, and we are continuing working to enroll and hire folks for that Upstate Healthy Start. Here in the Midlands, we serve Richland and Sumter counties, and in the Upstate, our grant includes Greenwood, Greenville, Anderson, Cherokee, Lawrence, and Lexington. Our primary focus is the underserved, focusing more on African-American population. We designed for communities with high infant mortality rates, and African-Americans, like I said a few minutes ago, are our primary target. Healthy Start AIM, we provide services and focus on case management, care coordination, group-based parenting education, and maternal health. And I know in the future that other Healthy Starts will also present their programs. We are different a little bit from the other Healthy Starts because our approach is more of a team-based collaborative care model, as you see. The next slide, please. So our team members, we have certified community health workers, we have a licensed social worker. Some of our community health workers, and including myself, we are certified lactation counselors. As you see, I'm the only nurse practitioner here. We have fatherhood coordinators that work with our men, doulas. We are working on getting our young ladies certified to become doulas. Certified community health workers are certified family planner health workers. We hired a health educator. We have a community consortium coordinator, and we have a contract with USC School of Public Health for our evaluation and data management. Community health workers are part of our, a big part of what we do here at Healthy Start. Public health, community health workers are public health workers working in the community. And this is a little insight about their job duties. You know, before I joined Healthy Start, I was not aware of the title as community health workers. So I've learned a lot about community health workers. Their job duties involve three main components: helping people navigate the health and human service system, providing culturally appropriate health education, building individual and community capacity, but they don't provide clinical or personal care. And I linked that website there from the South Carolina Community Health Workers Association. And all our community health workers are certified or working on their certification. And as I said before, Healthy Start mandated in 2019 their grant cycle for a licensed clinician, and that's why I came aboard here at Healthy Start during that time. Currently, I provide no direct services. I provide more support and consultancy for the staff and community participants. Also, I'm involved a lot with advocacy, interact with a lot of participants and their providers when needed. Provide a lot of listening. I have a lot of time to listen and support the participants. We call them participants in our program. So lots of clarifications. I love working with the first-time pregnant women. I also teach a class going to the ABCs of pregnancy, teach the childbirth class, do a lot of education, reproductive planning. I have an event in each November for our premature families in our community by teaching on prematurity awareness. And during this event, I let families share their stories on their prematurity journey. And I usually have one mother provide an overview to the audience about her challenges and successes with being a parent of a premature baby. And I thought it was really fitting. One day I was talking to one of the first-time pregnant women, and she said, my doctor's office asked me about a Tdap shot, and I said no. And then she asked me, so what is that? What are they asking me for? And so I kind of explained what the Tdap vaccine was, and she said she was planning on receive it. You know, I'm quite sure that the doctor probably explained it to her also, but I don't know the logistics behind it, but she said she was not aware of what that meant. So that's why she said no. So a lot of time, you know, I spent a lot of time talking with the young ladies and clarifying. Sometimes, you know, they're not really concerned what was said in a provider's office. So I have time to kind of clarify and work with them about some of their concerns. And I kind of do a lot of advocacy work, having them to reach out and discuss their concerns and how the most appropriate way to address their concerns. I'm also a part of a committee member with the feeder infant mortality and maternal mortality review committees also. And we have a wonderful social worker who addressed the social determinants of health. She provides a lot of resource connections to food, housing, transportation, etc. It's interesting being on the community part of Healthy Start from not being clinical, because you see how these social determinants of health really impact the patients. And like I said, we have a wonderful social worker that helps with crisis stabilization, screenings. We provide a lot of screening tools: alcohol and drug abuse, adverse childhood experience, intimate partner violence. She does the follow-up with these folks. She also, along with myself, provide a lot of support. She's great for mental health advocacy and case consultations. And our participants, so our goal, we enroll participants, pregnant women, and we are given a predetermined number per year. We also enroll some during the postpartum period, but our primary focus is on pregnancy. And we enroll postpartumly the first 30 days. We also enroll males, and we have male coordinators who assist and enroll our fathers. Our services end at 18 months. We are a voluntary program, and we have community partners, which is called our consortium, which was previously called a Community Action Network, CAN. And I know Kim would explain a little bit more about our community partners. In 2023, this is an overview of the services we provided. We served 972 participants. 305 of these were pregnant women and 225 were postpartum women. Also, you see we enrolled 67 men and we had 375 infants, children, and 107 were born during the period of 2023. 2023, this is a look at our pregnant and postpartum women we served, and you can see the average age, and most of them are African Americans. And we do risk stratification, so doing our screening tools. So we look at the obesity rate. This is by percentage of gestational type 1 diabetes, chronic hypertension. So I look at some of the main high-risk factors and I kind to stratify how we determine who's high risk versus low risk. And we also do this with a psychosocial impact, also unmarried, look at the high school education or less. And like I said, 89% of our participants are Medicaid recipients. And Healthy Start service, we try to improve access to quality health care services through our outreach, care coordination. We have individual and group health education and linkage to health insurance. We try to strengthen the health workforce, especially those responsible for providing direct services, with promoting and improving health equity by connecting with appropriate organizations. And how we serve, as I mentioned before, we use risk assessments to stratify about the frequency of visits. Our visits are mostly home visits. We do some occasional video visits. We use an evidence-based curriculum. We have group sessions, community events we attend. We are housed in some of the clinics. And that's how we enroll some during the clinics. Next, we provide a lot of screenings. Here are some of the screenings, developmental screenings. So each of our participants' families get ages and stages at 6 months and 12 months of age. We do depression screenings, intimate partner screenings, substance usage. As I mentioned before, we have targeted education and using an evidence-based curriculum. This is what the community health workers use. And we also pay attention to the current maternal trends. We provide a lot of literature and resources to our participants. And some of the topics we include preeclampsia, the biggie, the preterm labor. We educate them about the urgent birth warnings. Safe sleep is a big one. Weight management with obesity, kick counts, oral health, anxiety and depression, breastfeeding benefits, the importance of postpartum, prenatal care visits, mental health care, child safety, and it goes on and on and on. Our referral process, we get a lot of self-referrals, repeat pregnancies, or I had one young lady who called, was in the program about 10 years ago, pregnant with a new baby. And so she called, she remembered Healthy Start and the services that was provided to her, so she wanted to re-enroll. So we re-enrolled her. A lot of our participants tell their families, and we enroll through call-in. Also, we get agency referrals, in-house and external. We're working to get established in the EPIC system. We have a contract with a managed care organization where we get a lot of our referrals, community events. We're out in the community to the baby showers. And also we house in providers' offices, getting those referrals connected for our services.
Thank you, Harriet. Again, this is I'm Kim Alston, and I've been here for 27 years, and I direct this wonderful program. And Harriet mentioned some of the enabling services that we provide through case management, care coordination, and group-based education. But we also are charged to have a community action network, which we now call the consortium. And through that, we have to develop a strategic plan. And so we actually bring our partners together, those from the community as well, working with maternal and child health, as well as the faith-based and other community organizations and our program participants, in order for us to develop a strategic plan, looking at the social determinants of health to determine what we want to focus on. And so we did a focus group, and we'll be doing a focus group in the Midlands, but we've done that in the upstate to try to get the community to help us identify what social determinants of health that we want to focus on. We will be meeting on a quarterly basis. We would like for those on the call to join us and feel free to be a part of this initiative. We're trying to put together a provider action network so we can try to help look at some of the gaps in services and find ways in order for us to try to improve some of them. So that's kind of where we are with that. You can go on to the next slide. Wanted to talk to you about some of our wins. And these are two cute participants that are in our program. Our graduation at the end of the 18-month period, we make sure that we celebrate them and we allow them to come and we get them dressed all up in their cap and gowns. Their mothers are there. They give us testimonies. We do in person as well as virtual when we're not able to do so. And then the mothers, the interesting thing about that, even though they're graduating from the program, they actually cry because they don't want to leave the program because they've been so connected and been supported, and they say that they feel valued. So these are some other things that we look at as wins that you'll see here. Can you go to the next slide? Because I know we're kind of getting low on time. Some of the challenges that we face is the caseloads, because based on the funding that we receive from the federal government, we actually are only allowed to hire a certain amount of staff. And so we have more caseloads than usually, and it's more than what we would like because we wanted to try to make sure that we serve the required numbers that we're supposed to. And then we try to take on more because we want to try to help those that are in need. We have inadequate resources, and I think it's great for us to point this out, that not only is the medical side important, but as we are working to provide services, working in the community, we're finding the resources that are limited for us: housing, eviction notices. We have individuals living in shelters, and then especially for families, mothers with children, we find it hard to find places for them. Lack of follow-up through participants for meeting some of their appointments, and the access stigma around them and having the trust system, building that trust with working with them. We have individuals to start breastfeeding. We feel that we're doing good with that, but we want to make sure that we're trying to get them to continue breastfeeding at least up to 6 months. And the complex participants that we have a lot of participants that have a lot of mental health needs. You can go to the next slide. I wanted to share with you just some testimonies from some of our participants. Midlands Health to Start has been so helpful to me and my family. We've been in the program twice, and this time has been personal and a blessing. So you'll see these are some of the other ones. Health to Start has been an amazing program. The unwavering support is unmatched. You can go to the next slide. We have a lot of information we want to share, but I want to allow us the opportunity to get to the case study. So this is a set of some of our participants. So you can see that some of the things that we've been able to work with them through. For this individual, her having 5 children, and she gave birth to a youngest of 2, and the different things that she was faced with along the way. But what we're trying to say is that with the services that we've been able to work with her and link her with, and Harriet being available as a nurse practitioner, providing guidance, and the social worker and the rest of the team, you'll see that over time her situation improved, and she's in a better place now. And we've been able to help her bridge the gaps between the community, the providers, and the organization. And so this is what she said about the work that we had required, had provided to her. So you can go to the next page. This is another one, 21-year-old African-American, second child. She was dealing with post-delivery complications with infection resulting in a G-tube. She continued to work with the program and the community health worker and the social worker and the nurse practitioner sent her to the various, linked her to different programs and provided advocacy for us. And now she's stronger, and she's in cosmetology school, and the baby is 7 months and talkative and thriving. So you can go on to the next one. And we're gonna go through this, past this one, and you can go on to the next one. I just want us to get through the end. And then here, we want you to know, and Harriet's going to be sending the information to Rachel so you can join us for our annual infant mortality and maternal mortality awareness symposium. That's going to be Friday, September 27, 2024, and we'll be providing more information. So if you would just mark that date on your calendar, and we'll would love to have you at our event. You can go to the next. And we'll take any questions that you have, but I do know that Harriet has a very interesting case study she would like to present to you.